Good evening, everyone. Thank you, everyone, for your time today. I am Dr. Sneha Shetty, the medical manager for oncology and your host for today evening. Uh, to thank you, first of all, everybody, to make time to attend this meeting. We are looking forward to a quite an insightful discussion, which is precision oncology in mCRC treatment. So, before we begin, we'll just quickly encapsulate of what is going to be the objective setting for our today's meeting. As we all are aware that CRC is increasingly perceived as a personalized disease where biomarker is being an important decision maker in the kind of therapeutic regimens that we are going to be administering to the patients. Keeping that in mind, Merck is pioneering personalization in mCRC, with sotiximab being the first approved anti-EGFR therapy in mCRC, to personalize treatment in RAS wild-type metastatic CRC, and to highlight the role of tumor-sidedness. And with that as a background, we are proud to announce that we are launching NGS testing for mCRC patients, which will be accessible through our co-payment support program. So the multiple options to enable biomarker-driven treatment in mCRC, this is the panel that Merck has launched, which is for NGS, tissue biopsy, and liquid biopsy, where for tissue biopsy, we have NCCN recommended 12 gene panel, which is KRAS, NRAS, BRAF, ERBB2, MET, NTRK1, NTRK2, NTRK3, POL, POLD1, RET, and DMMR. And in NGS liquid biopsy, we have KRAS, NRAS, BRAF, ERBB2, MET, NTRK1, NTRK2, NTRK3, and RED. Along with this, we also have RT-PCR tissue biopsy, which has a TAT of 5 days for KRAS, NRAS, and BRAF. And for KRAS and NRAS, the TAT is for 3 days. Moving ahead, Merck is committed to enable biomarker-driven treatment in mCRC patients. And to enable that, we are looking forward to an insightful meeting where we will have a dedicated 60-minute discussion on how the biomarker investigational workup defines the therapeutic treatment regimen for patients in mCRC. To go ahead with this session, I would like to introduce the chairperson for today, which is Dr. B.K. Smriti. Quickly introduce Dr. B.K. Smriti, ma'am. She's a senior consultant and medical oncologist at Bombay Hospital Institute of Medical Sciences and Leelavati Hospital and Research Center. She's been on international panel of experts in advanced breast cancer 2017 and 2021 Lisbon. She's also a co-chair of the Scientific Committee for Gynecologic Cancers, ESMO Asia Congress 2022. She's received Times Lifetime Achievement Award for February 2022. She's also been invited and as a faculty at several national and international meetings. And she's the president-elect of Indian Society of Medical and Pediatric Oncology. Thank you so much, ma'am, for giving us the opportunity and chairing this session today. Over to you, ma'am.
Yeah, please can I have the control of my slides?
Yes.
Just give me a second, ma'am.
Yes. So thank you for that very generous introduction. I'd like to thank Mark for giving me this opportunity to chair this very interesting session on the role of precision oncology in metastatic CRC. And I'm very privileged to do so because in the past 30 years, I have seen the total evolution from just basic chemotherapy like 5-FU leucovorin to combination chemotherapy to the advent of targeted therapies like cetuximab and bevacizumab. Then, coming to the sidedness and its implications for treatment decisions. And last but not the least, which is the main focus of today's discussion, is the advent of all the biomarkers, which then enable us to personalize treatment further. So can I have my first slide, please?
You can just click on the slide once, it will move, ma'am.
So can you take it back? Yeah. So this is, as I mentioned, a very rapidly evolving treatment landscape. And why is the treatment decision so complex? As I said, we have moved from what is called as the anatomical decision making to biological decision making, and with multiple lines of therapy, especially in view of the expanding biomarker panel like RAS, BRAF, MSI, HER2, NTRK, etc., mentioned by the previous speaker, and the differentiation anatomically. And all this is now been incorporated into the NCCN ESMO guidelines, and also giving us what should be the sequential use of therapy based on the molecular profile. And then, of course, we can say that now metastatic CRC is not one disease, but is actually broken up into various buckets which are biologically driven, as mentioned in the last paragraph. Now, what guides this treatment? So, it is first, of course, the anatomical side, the biomarker status, the performance status, comorbidities, tissue versus liquid biopsy, and prior therapies, response, and toxicities. So, we can't forget even the toxicities of the prior therapy, which may then impact our decisions. So, the update reflects the evolving treatment landscape. So, if you look at the ESMO Precision Medicine Working Group, you can see that the consensus guidelines are focused on these important areas, which Dr. Gore would cover. One is the RAS wild type, the MSI high, the BRAF mutated, liquid biopsy, and the emerging biomarkers. And the objectives is to understand this evolving landscape, how to use these biomarkers, for which we would need the NGS testing, what would be the importance of liquid biopsy in this setting, to review the current global guidelines, what should be the tumors, the treatment sequencing in RAS wild type, and the sequencing strategies of the anti-EGFR therapy, as well as re-challenge, to discuss the various subsets, and also to share the perspectives on how to optimize therapy. So I think with this introduction, I now call upon Dr. Advait Bore to speak on the subject of the current treatment guidelines in metastatic CRC. So he's going to have a close look at these guidelines. So Dr. Advait Kore, as you all know, is the Associate Director, Department of Medical Oncology, Saifi Hospital, Mumbai, consultant medical and pediatric oncologist, hemato-oncologist, BMT physician, over 15 years of clinical experience across leading institutions, Executive Director, Indian Journal of Cancer, Faculty for DNB Medical Oncology, Clinical Research in multiple phase 2-3 trials, and expertise beyond precision oncology, solid tumors, also hematologic malignancies, and transplant. So with this, I call upon Dr. Advait Gore to make his presentation.
Thank you, madam. Can I get the control of this? Dr. Sneha? Yeah.
Sir, you can click on the slide once. It will move.
Okay. Yes. So as madam mentioned, we have had the privilege of actually witnessing firsthand this really remarkable transition of approach to treatment to metastatic colorectal carcinoma. And for years, our strategies were more generalized, but today we are in the world of precision oncology. And that is what in over the next 10 minutes I would want to cover. On the critical part of this evolution, how these recent guidelines, landmark trial data have reshaped how we treat these patients in first line and even later on, and treatment decisions. And what we see here over the last 3 to 4 years, there has been a flurry of guideline updates from the ESMO, the ASCO, and especially the recent Pan-Asian ESMO consensus guidelines. And the central theme of all these guidelines are to try and move away from one size fit all therapy and come to a individualized approach. Now, in terms of molecular testing, there have been comprehensive molecular testing which have been used, ideally a next generation sequencing to identify biomarkers. Um, the RAS wild type, the BRAF mutations are the standout ones which don't generally respond to the conventional treatment and need specific therapies. The MSI high metastatic colorectal carcinoma has been a completely different success story in itself. However, in colorectal carcinomas, less than 5% patients do fall into these categories. There is also the pivotal role of tumor sidedness that we have understood, and it's a concept which really has dramatically changed the treatment selection and patient outcomes. However, there is also an ever increasing need for emerging biomarkers as more and more targeted therapies get approved in this clinical space. So, in terms of first line treatment for left sided RAS wild type metastatic CRC, um, this essentially includes the splenic flexure, descending colon, sigmoid, and the rectum. And for patients, those who are RAS wild type left sided primary, the evidence is very, very clear. The ESMO guidelines recommend a chemotherapy doublet plus an anti EGFR, and it's giving it a grade 1 level A recommendation. And this recommendation is not just based on a single study, but there is a real powerful body of evidence through multiple phase 3 studies. The FIRE 3, the CalGB, SWOG 80405, these compared the anti EGFR therapy cetuximab with BEV, which demonstrated a significant overall survival benefit for cetuximab in the left sided group. The paradigm study is a more recent Japanese study which has consolidated this finding, showing a median overall survival benefit of about 3.6 months with panitumumab plus chemo versus BEV plus chemo. And what all of these trials tell us that for this specific patient population, an anti-EGFR agent is not just an option, it is the preferred first-line therapy which provides more deeper and more durable response. Now, here is the FIRE 3 data where we see that Erbitux addition adds on to the overall survival benefit. The CalGB also showed the same, and the paradigm showing a 3.5 months delta. In the paradigm trial, the overall survival curves crossed at 28 months. This is what we see here, that the chemotherapy plus BEV arm going down and the panitumumab plus FOLFOX arm showing an improvement in the median overall survival. So the ESMO guidelines recommend treating with targeted agents until disease progression, and that has also an approach used in the CRYSTAL and the OPUS study. And these guidelines do recommend maintenance to reduce the chemotherapy-induced toxicities, and also depends on what is the first-line chemotherapy used. So if an anti-EGFR agent and an oxaliplatin-based chemo is used as a first line, we can continue with the 5-FU, leucovorin, or capecitabine along with the anti-EGFR agent. The same goes with the BEV. But in terms of cumulative toxicity, we know that irinotecan can tend to be more toxic than oxaliplatin and 5-FU. So maintenance strategies have been used across, and 5-FU, leucovorin, or a fluoropyrimidine with an anti-EGFR is considered a valuable maintenance option in RAS wild-type metastatic CRC, or even EGFR monotherapy, especially in left-sided tumors, can be considered. In terms of switching from cetuximab to bevacizumab, there have been data where starting with cetuximab plus chemo can provide benefit over bevacizumab and chemo, which extends beyond first line, especially in the RAS wild type left-sided metastatic. We see that the first line therapy with cetuximab chemo does a longer PFS benefit as compared to BEV. And whenever that we are looking at second line BEV plus chemo, and then third line maybe re-challenging again with an anti-EGFR, does help bring about responses to the clones of disease, looking at an ultimate PFS of about 40 months of survival. Now, in terms of left-sided disease, the RAS wild type re-challenge of cetuximab in third line and beyond. The current ESMO guidelines for third line and beyond include many treatment options. but these are TAS-102 plus BEV, single agent anti-EGFR, uh, panitumumab with a MCBS score of only 2, irinotecan cetuximab as a single agent chemo plus anti-EGFR, single agent regorafenib or TAS-102, and fruquintinib is also additionally recommended in ESMO Pan-Asian guidelines. The rechallenging theory for anti-EGFR is based on this clonal evolution Santini hypothesis, which explains the rationale for this rechallenge. That initially there would be multiple clones, some cetuximab sensitive, others resistant, and the resistance is predominantly driven by acquired RAS and EGFR ectodomain clones. Once there is tumor progression, an anti-EGFR agent-free interval is preferred in the second line, and where the RAS EGFR mutant alleles decline upon the anti-EGFR withdrawal, leading to the tumor to regain sensitivity to an anti-EGFR agent rechallenge plus or minus chemotherapy. So treatment for the RAS wild type in terms of right-sided disease. We have the guideline recommendation of a first-line anti-EGFR and doublet chemo for right-sided RAS wild-type metastatic CRC, and this is in situations when cytoreduction or a higher response for conversion therapy is a goal. And these tumors, the consensus, including the ESMO 2023 Pan-Asian guidelines, which were recently shown, that it does mention that for the right-sided RAS wild-type anti-EGFR and doublet chemo is showing a higher response, especially for conversion. And this is based on the data from the Crystal, the Taylor, as well as the FIRE-3 study, and cetuximab containing regimens are an option for whom in patients where a rapid cytoreduction, a faster and a deeper response is specifically needed as a treatment option. Early tumor shrinkage was something which we have all seen when this data was presented about 15 years back, and early tumor shrinkage in right-sided RAS wild-type metastatic CRC. The FIRE-3 study did show that 57% patients who were treated with cetuximab did achieve an early tumor shrinkage, which did translate into a median overall survival of 27.9 months in patients who had more than 20% of early tumor shrinkage. So that could be another clinical marker by which we can assess these patients. So recommendation for targeted therapies in other actionable mutations. We do see that for first-line therapy in RAS mutant, we are looking at chemotherapy doublet plus bevacizumab or a triplet with bevacizumab. In BRAF mutant, we have the encorafenib, cetuximab, FOLFOX as a combination. If patients have progressed, there is data from the Breakwater and Beacon, which I'm sure Anant would cover during the panel discussion. For a deficient MMR or MSI high, a Pembro or Nivo-EP, which is the niche protocol, is used. And if progressive disease, we do have the Keynote 177 and Checkmate 8HM data looking at these group of patients. In second line, in the RAS wild type anti-EGFR naive, BRAF mutated deficient MMR or MSI high subgroups, or even in KRAS G12C mutant, we do have the distinction for the left versus right in second line, where FOLFIRI or irinotecan with cetuximab or panitumumab is a preferred option in left colon, and anti-angiogenic plus chemotherapy combination for the right-sided disease, encorafenib plus cetuximab for the BRAF V600E mutant, and in the deficient MMR, either a Nivo-EP or a Pembro as a single agent or dual IO therapy. For the G12C mutant, we do have the KRAS inhibitors in terms of sotorasib and panitumumab and cetuximab with ADA. What has also changed is the identification of mutations based on the liquid biopsy also. And traditionally, the tissue biopsy has always been the preferred choice for detecting these mutations. However, in 2022, the ESMO Precision Medicine Working Group released the guidelines recommending use of liquid biopsy especially when quick therapeutic decisions are required, when tissue testing is not feasible or tissue is not available, and when we are trying to consider re-challenge of anti-EGFR. And these biopsies preferably should be carried out either on the primary tumor or a metastatic site. And generally, these liquid biopsies has a turnaround time of less than 10 days. ctDNA has been validated across many labs, even in India, where these testings are available. And when we are looking at liquid biopsy, it does give uh, really complementary results along with the tissue biopsies too. So, in summary, the updated guidelines recommend tailoring first line approach, especially for RAS wild type metastatic CRC. Anti EGFR and chemotherapy are now recommended as the only option in the left sided RAS wild type as per the ESMO 2024 guidelines. And we've seen the cetuximab plus chemo offering a median overall survival of almost 40 months. We should be continuing the anti-EGFR agents in maintenance setting to achieve optimal survival benefit without increasing the chemotoxicity. In the right side, RAS wild type anti-EGFR plus chemo can be offered only when cytoreduction is the goal due to a numerically better overall response rate achieved versus the anti-VEGF. And it is important to consider other recommended option as per guidelines to achieve a better patient outcome. I thank you all for a patient listening, and over to the organizers. Thank you, Smriti madam.
Yeah. So I would like to thank Dr. Gore for that excellent talk, and which clearly covers all the guidelines and the way we are moving forward in metastatic CRC. And to put this in the proper clinical perspective, we call upon Dr. Anant Ramaswamy to head the panel discussion and moderate it. He is the professor of medical oncology at TMH Mumbai. He has progressed through its academic ranks at the TMH, and also he is now the professor of medical oncology since 2021. He has cleared his DM and MD from the various universities as mentioned, with an extensive experience and as an investigator and sub-investigator in many clinical trials across various therapeutic areas, and these span phase 2, phase 3, phase 4, and author of numerous publications in peer-reviewed journals, and he's a member of ICON. So with this, I request Dr. Anant Ramaswamy to go ahead and introduce the panelists and the faculty for the panel.
Dr. Anand, you can click on the slide once. You can have a control, sir.
Okay. I just one second. Sorry. I'm not able to move it. Oh yeah, okay, great. So thank you, BK Smithy madam, for that introduction, and thank you, Mark, for allowing us the opportunity to moderate this session. My job is made easier because of Dr. Advait's extensive coverage of the guidelines. But let's just see how different people treat these cancers in the clinic. With me, I have Jyoti madam, who's one of the senior medical oncologists and is currently at Apollo Cancer Center. Dr. Manish Jain, who's Director Medical Oncology at Ruby Hall Clinic. Dr. Amol, who's Director Medical Oncology at Nagpur Max Healthcare. And Dr. Taha, who's a Senior Medical Oncologist and Hemato-Oncologist at MOC Indore. I think Ashish sir is not there. Am I right? Is that right?
Yes, sir, that's correct.
Yes, sir.
Yeah, okay, great. So I'll just go through some of the opinions on how we treat these cancers, because the guidelines are pretty straightforward in this setting. So this was already covered. This is the standard biomarker recommendations as per the various guidelines. These are some of the questions I'll be trying to go through. Is sidedness, RAS-RAF, and MMR enough? What's the data with regard to downstaging with anti-EGFR directed therapy? How strong is the evidence for use of anti-EGFR directed therapy as second line therapy? The exciting new data on BRAF directed therapy, anti-EGFR rechallenge, NEURAS, and KRAS inhibitors. Right. So this has been shown that, if you want to treat your first line metastatic colorectal cancers, you probably need to give anti-EGFR first. As you take it to later lines or don't give it, your survivals decrease. And this is shown. Again, this has been shown, the paradigm and the FIRE 3. So my first question would be to Jyoti, madam. Madam, are you there? Is Dr. Jyoti
Yes,
there?
yeah. Hi, Ananta.
Yeah, good
Good to
evening,
see
ma'am.
you. Yeah.
Yeah, good to see you. So, let's say your garden variety of metastatic colorectal unresectable cancer comes, and you have, let's say, sidedness with you. You have a RAS trap with you, and you have an MMR. Is there anything else that will help you in deciding to give anti-EGFR directed therapy? And this is assuming the patient is fit and willing for all treatment options. Anything else that would help?
So I think sidedness is extremely important, as well as the status of RAS, RAF, and MMR. And with that, we can decide upon that, what kind of treatment we are taking, whether it's left-sided or right-sided, and what kind of mutations, these important mutations are there. Additionally, we may consider doing a comprehensive NGS so that we will get to know about the other marker status also. But in first line, I think these are enough.
Okay. Going forward, do you think any other markers will play an important role? Or do you think largely we are going to stick to these four things, in deciding treatment?
So I think going forward, BRAF status, HER2 status, POL status, NTRK status, and HER2 status, I believe, is extremely important because although they are in less percentage, but whenever they are there, we are having some targeted drug to tame these targets. So that's make the therapeutic relevance, and I believe it is important.
Okay. I'll take one more on that. Dr. Manish?
POL also, I'd whether I said or not.
Yeah.
Yeah.
Dr. Manish, your thoughts on this? In your patients who comes to you first up, is sidedness, RAS-RAF, and MMR enough, or do you look at anything else while deciding treatment options for anti-EGFR directed therapy? Is Dr. Manish there? Okay. Dr. Amol, maybe can you take that?
Hi, Anand.
Hi,
Hi,
Dr.
good
Amol.
evening.
Good
Yeah,
evening.
so as rightly said by Dr. Jyoti also that sidedness is most important, we know, and then obviously RAS RAF we tend to do nowadays NGS, but yes, before that all RAS testing, RAF and MMR, I think it's good enough while selecting our patients on anti-GFR directed therapy, but still I would say the first one would be sidedness.
Okay, so sidedness is important. I think Dr. Manish has joined us. Maybe I'll take his opinion also. Your garden variety of, advanced colorectal cancer comes to you. And is sidedness, RAS-RAF, and MMR enough while selecting anti-EGFR, or do you want something else? I think, yeah.
Yeah, sorry, Anand, there was some issues with my
Sure. No problem.
I couldn't hear you.
Is this enough for you to select anti-EGFR directed therapy, or is there something else that you use, before using anti-EGFR directed therapy?
Yeah, I agree to Dr. Jyoti, ma'am, that we generally would do this basic test. We will do all the RAS, RAF, MMR, HER2, and these days we also order an NGS. So if there are some emerging therapies which are coming, though they are low, NTRK is there, MET is there, ALK is there. You can do EGFR, ECD, which may be in liquid biopsies subsequently. So there are multiple things which are available. But yes, basically on a tissue, I would do at least this 4-5.
Okay, great. The reason I'm coming to that is, this is something that interests me, is that, let's say, a lot of us do HER2 in colorectal cancers, or it comes as part of the NGS panel, and you see an amplification, for example. Does that turn your head towards anti-EGFR, not towards anti-EGFR? Does that, what does the HER2 status tell you? Because as of now, there's no first line HER2 directed therapy. So what do you do with this? And, maybe Dr. Amol or Dr. Manish, any one of you can start with this.
Yeah, I would just go with the basic treatment. Like if it is an KRAS, NRAS, patient who is fit for an anti-EGFR, I would not go with an HER2 treatment upfront. I would go with the basic treatment. The only thing which has come up is the encorafenib, which could be added in first line. Other than that, if you are having a standard, you can go with FOLFOX and anti-EGFR. You don't need to go for an HER2 treatment upfront.
So would it
It
help you
helps
with,
you to
yeah,
explain the aggressiveness of the tumor. It does not
yeah, yeah,
change your treatment as
yeah,
a front line.
yeah. That's the point I wanted to make, that it's probably prognostic, but it's not going to help me with treatment initially. That's what I was trying to do. There's also some data for PIK3CA, but the thing that I found quite good was this paper which had just come up, let's say 3 months back, where they looked at methylation status as a biomarker. And so this was done as part of the deeper study, which involves Rituxan and chemo. And there they showed that if you're, a high methylator, your outcomes are very bad per se, and probably not as good with anti-EGFR directed therapy also. Now, I understand this is not used in the clinic commonly, but is it something that, probably grabs eyeballs? And Dr. Amol and Dr. Jyoti. Yeah.
Well, so I mean, as you said, it's not been practiced in, I mean, clinical practice. So I really wouldn't go for that. But yes, anti-EGFR direct therapy, we all are well versed with that, and I mean, we are using it since long. So I mean,
Okay.
my choice would be for anti-EGFR and not to that. And what Dr. Minijan also, I mean, same. I'll also echo that. HER2 and I mean HER2 therapy we won't be using, and if we have an anti-EGFR direct therapy available.
Yeah, sure. So let's say that one of your patients, comes with a whole exome sequencing and shows you this report. And he says, you know what, my methylator status is very high. What will you do? This is all hypothetical, but I think in some time we will come across these kind of reports. So would you then say that, okay, let me think, or would you say, let's stick to standard? That's my question.
Yeah, so still, since we have very little knowledge about this methylation status, I would still tell him that I would stick around with the standard of care, I mean, standard what we have practiced and what we got the results with that. And
Yeah, fair enough. I just put you in a spot there.
yeah.
Interestingly, the high methylator status correlates with more BRAF mutants and more right-sided tumors, just as information. Right. So the next thing is this was briefly covered by Dr. Advait in his talk, that should you use it?
Anant, just one second. I think that
Yeah,
was very interesting slide which you have shown, and as you very rightly spotted that patients these days, they are all kind of patients, and they're coming with entire sequencing in hand. They want to know everything, and they read everything, and then they want to really act upon the reports. So perhaps we are not reached that we are directly
yeah,
acting, but yes, is important, and perhaps these kind of cases should be discussed extensively in molecular tumor board. And as you rightly pointed out, that these may be and coexist in BRAF mutation, etc. And if we know already that these status are associated with very poor survival with the conventional treatment, we may err towards adding something. That's what.
yeah, fair enough. Dr. Taha, your thoughts on this? I understand that it's emerging, but you have a lot of labs which are now saying we'll give you these reports. So what do you do with them? Will you change therapy on these reports, or say, you know what, let's stick to standard?
So currently, I think what data is available, I would stick to the standard recommendations, but would also counsel patients and keep them under close follow-up. Probably do an early scan or other whatever clinical parameters
Yeah,
see and all at a frequent basis. If any progression, if you feel it's an aggressive disease, switch early rather than
yeah,
later.
yeah. I think the prognostic implications are a lot. Therapeutic, I agree with you. We are in a gray zone there. Fair enough. Okay, coming to the next one is downstaging with anti-EGFR directed therapy. And again, this was brought out very nicely by Dr. Advait, that there are multiple studies which says that your response rates are pretty good with chemo plus anti-EGFR. So I'll start with Dr. Manish again. Let's say you have right-sided tumor, and thankfully it is oligometastatic disease, and it is RAS RAF wild type, would the overall response rates push you towards using an anti-EGFR, or would you say no? I want survival as an endpoint. I'm going to go with chemo plus Bev. Your thoughts?
See, there is a clear advantage of left-sided tumor having a better response with an EGFR treatment compared to right side.
The left is easy. I'm going to put you on the spot and ask you right.
Right, you have two choices. You can go with an EGFR treatment if it is an patient who has a EGFR positive, then you can still go with bevacizumab. Also could be a choice in that kind of situation. You could use either one. So it's not like I would use if I get the reports. If the problem is sometimes if the patient's load is too much, disease load is too much, there are multiple liver mets, and the EGFR report is not available, then we sometimes tend to use right-sided tumor straight away with bevacizumab, and we don't wait for an EGFR report to come in. But for a left-sided tumor, we wait with a simpler treatment. We start with no target in the first cycle. We wait for a report, then we add up in the next cycle. But for a right-sided, we do go with FOLFIRINOX with bevacizumab straight sometimes. So that is how I would treat.
So
and
if
if I get a report, I may use
Okay.
cetuximab before
Okay.
bevacizumab. I would not wait for bevacizumab then.
Okay. So you might use it. That's what the thought I could get. Okay. Jyoti madam, I'll give you a specific scenario. It is oligometastatic right-sided cancer. You have 2 to 3 liver mets. Okay. And by luck, you got an early RAS-RAF report, and both of them are wild. Would you be tempted to use an anti-EGFR because it's borderline resectable? Or would you say, no, it is a right-sided tumor, I'll go with chemo plus Bev? Your thoughts?
So I think, if we are having a report in hand for the potential resectability, especially if patient and family are well versed with the situation, patient is fit enough, and we are really targeting the maximum cytoreduction and resection, I would urge towards using.
Okay. So I'll just show you the next slide, and then I'll go to BK Smriti ma'am because she's raised her hand. This is the data from the Cairo 5 clinical trial. And they looked at exactly this question that, initially unresectable colorectal liver metastasis, should you consider anti-EGFR or Bev? This showed no difference. This is close to a 250 patient study. So we should be careful using anti-EGFR. I agree with the guidelines, but we should be very careful giving anti-EGFR directed therapy in right-sided cancers. BK Smriti ma'am,
But
please.
isn't it, Anand, this is only a post-hoc analysis and...
No, they did it separately in left and right-sided tumors, and the survival, it did not achieve its primary endpoint, ma'am. So,
but the heading suggested post-hoc analysis of Cairo 5. That's what I was just wondering.
The primary endpoint was not reached. That's
Anand, I would say that sometimes going with bevacizumab also causes the liver toxicity. So
fair enough.
The surgeons are not very keen. They would prefer that you give cetuximab much safer.
Yeah, I agree with you. Yeah.
Fair enough.
I have the report. See, I told you two scenarios. If the tumor is very bulky and I feel that it may be plus minus for surgery and it's a right-sided tumor, I do not wait for EGFR. I go with bevacizumab and FOLFIRINOX if the patient is young. And if the patient has got a limited resectable disease and I know that I have to go only for 6 doses and then go for surgery, I would prefer giving cetuximab. And there is no difference between bevacizumab and cetuximab as such. So you're not going to either achieve bevacizumab as an extra thing in that situation, but you will be saving the liver much better.
Okay, fair enough. Yes, madam, please.
Yeah. So what I want to make a point is that we really can't discredit that data of the ETS. Now, when you have, you must always discuss these patients with the surgeon. So it has to be a multidisciplinary team. And if the surgeon feels that, yes, it will become resectable, then I wouldn't want the patient, to be subjected to too many lines of chemotherapy, means beyond 4 or 6. So I would go for that treatment which is going to give me a better depth of response, and then I would use cetuximab with chemo. But if the surgeon says, look, this is not going to become resectable, it's very doubtful, then of course I would use the triplet therapy or doublet with Bev. So I
Fair
think the
enough.
multidisciplinary team is very important here to discuss with the surgeon the resectability, because you know that if metastectomy is done and we do not harm the liver much, then that is the time these patients do pretty well, better than those who are not resected.
Sure. I agree with you on the MDT point totally, ma'am. I think we need to get their opinion, the surgical opinion on whether this will come up for surgery at some point in time. Fair enough. So going to the BRAF directed therapy, I think till maybe 4 or 5 years back, this was a dead end. Patients with BRAF mutants hardly survived a year. But over the last 5 years, I think that has changed. You had the initial second line data, and then you had the first line data that chemo plus encorafenib plus cetuximab. And the point to note here is the overall survival of 30 months. This was unheard of in BRAF mutants. In fact, even the comparator arms in this study did well, 15 and 20 months. But the idea is that, this is, if you have access to this, I think this is the treatment option to use. The worry is the toxicity. I think almost 1/4 of patients had to stop treatment because of toxicity. And in a few patients, I have used encorafenib, cetuximab, and it is tough. So I'll start with Dr. Taha. What proportion of patients with colorectal cancer in your practice are BRAF mutants? Rough estimate.
So very less. I'll say probably less than 5%, or probably lesser than that maybe.
Okay. Dr. Amol?
Maybe around 2 to 3%, Anand, not more than that.
Okay, so definitely rare. Okay.
Yeah.
I'll come back to Dr. Taha then. So definitely the survivals are great, right? This is something we have not seen earlier. 1/4 of your patients, though, will not be able to continue treatment for long. Does that bother you, or how will you deal with it? Because and do you have any experience using the combo encorafenib and cetuximab?
No, sir. Unfortunately, I've not used the combination yet.
But your thoughts on the combo and the risk versus benefit ratio?
So with the as such BRAF patients overall don't do well, but getting a survival of more than 30, I mean the survival of the trial have shown, I think I would probably find the right patient for that combination and would like to offer it to the patient, showing them the results. So would go ahead, seeing the
Okay.
results.
Anyone on the panel with experience using encorafenib and cetuximab? Dr. Manish, Dr. Jyoti, anyone? BK Smriti, ma'am?
No, I have not used it.
Okay. Okay. So I've given the encorafenib and cetuximab alone for now 4 patients, and it's reasonably tolerated, but it's not easy. So I'm not sure how you'll give it with Folfox, but yeah, I agree with Dr. Taha that uh, 30 months is like any other colorectal cancer patient then. So we should consider its use. Uh, since encorafenib is not yet available in India, has anyone used any other BRAF directed therapy? Anyone on the panel? Yes, BK Shruti ma'am. Yeah.
For lung cancer.
So
Okay.
this is a long time back. That is when we had dabrafenib and cetuximab and a very resistant patient who had run through all the lines. And BRAF emerged as the only other now remaining targeted. I have used, but as expected, the results were not good. I mean, that is at the patient's insistence. So I think we have to go with this data and not use any other
Correct.
BRAF inhibitor.
Totally agree with you, ma'am. And the other thing is that the dabrafenib trametinib is in the drug insert, it is specifically written not to use in BRAF colon. It's tumor agnostic for everything but colon, because they say it's intrinsically resistant. So, and as madam said, in her experience, it didn't work. So kind of makes sense. Right.
I
Great.
think that
That was-
works good in melanoma cases, but in other cases, it's kind of.
Yeah, no, ma'am. I think the approval is tumor agnostic except for colon. I don't know
No,
why.
that's true, but they
But
that's what I'm saying. In practical experience, they work really well in melanoma. That's what
oh yeah,
has been seen there. If the disease pace is really fast, and if you start with BRAF MEK inhibitor, they really show a good response. But in other tumors, I think this kind of response is not seen.
yeah. I used it in one patient, and that patient didn't do well. I can't remember, but yeah, it didn't do well in that one patient.
And as
Sure.
I said, this was used when we didn't have this data, and there was no encorafenib, and we had
Yeah,
it was a highly resistant case who insisted on some treatment on this based on
sure,
this.
sure, ma'am.
You can even use vemurafenib.
Yes, there is phase 2 data for vemurafenib also, and vemurafenib plus chemo as well. And I think vemurafenib plus one other agent also is there. Yes, you're right. You used it? I
No,
personally not. No, no.
I have not
Okay.
used it.
Okay. Right. Coming to anti-EGFR directed therapy as second line therapy, and this is obviously in patients who have not received anti-EGFR directed therapy as first line. So let's say you have a left-sided colorectal cancer, which for some reason you gave chemo plus Bev, and it was RAS/RAF wild type. Dr. Amol, I'll start with you. Your thoughts
Yeah.
on, the probable efficacy of anti-EGFR. Of course, you can use it, but how effective do you think it is?
No, so left-sided, RAS/RAF wild type, I would definitely use it. Since patient initially received BEV, that's what you said, right?
Yeah, not received anti-EGFR. Yeah, for some
Antigen. So
reason. Yeah,
no, so definitely patient relapse second line. I would love to use it. Antigen
sure.
doublet. Yeah.
Okay. Dr. Minish,
Yeah,
would
it
you?
works. It
Okay.
works. I would use it.
Yeah.
I would use it, and even sometimes we have rechallenged patients, and they have also responded. So it's like if you have an mutation which was not earlier targeted, you can reuse it, and you are
Sure.
anyway changing the chemotherapy. So if you
Yeah.
used Volpox, you are giving Volpiri with cetuximab or
Yeah.
panitumumab. That is fine. You can use it.
Yeah. So, I mean, I've just shown these three studies to say that, and probably in second line, sidedness is not as important. So if you're RAS/RAF wild type and you've not used it in the first line, you probably, will achieve some response using it in the second line, irrespective of sidedness, because, sidedness kind of loses its importance, during further lines of therapy. Yes, madam. I think PK Smriti ma'am wanted to say something.
The same thing. When this sidedness came after the CLGB 80405 and Fire 3, I remember Eric Van Cutsum's important statement in the ESMO GI. He said that this sidedness is important only in first line, not in subsequent lines. So
Yes.
even then, it was known that it's only meant for first line. In subsequent lines, definitely you can use it.
Yes. And subsequent to subsequent lines, I will come subsequently in my slides. So going over to the next bit, and this is where, a lot of discussion and hot topics have emerged over the last couple of years. Anti-EGFR rechallenge and liquid biopsies. So, let's say that you have a patient whom you've used anti-EGFR directed therapy with chemo in first line, and then you gave chemo plus Bev as second line. You have 5 to 6 options as third line. I'll start with maybe Jyoti ma'am. What influences your treatment in third line besides performance status? Only 30 to 40% of our patients actually come to third line. So besides performance status, what influences your treatment?
So I think, Anand, the treatment free duration is very important. How long the patient is free of that EGFR therapy is important, and I would like to use the as a re-challenge, and we have evidence also that for a time being, if that particular therapy in many cancers, and also in particularly in colon cancer also, if patient is EGFR therapy free, then the sensitive clones again emerge, and we can again target, and we see response. About the biopsy, yes, I would prefer to do a biopsy, especially a liquid, which is the turnaround time is also less, and it is ease of doing thing. Although, if it is very easily accessible, then even tissue biopsy is fine. But for various logistic reasons, I will prefer to do liquid.
Fair enough. So you would definitely consider anti-GFR, and so would you base it on your liquid biopsy result, or would you say, you know what, it's been 6 months since I've used anti-GFR, I'm just going to use it? What would you
So
base
if
it
I
on that?
get the result, that will further support my decision, give more confidence. But I would not say that is, 100% that, if it is not there, I will definitely not use. But that will give us additional, safety margin that perhaps the treatment is going to work.
Okay, so your primary concern would be treatment-free interval, and you take a call on that, right?
Yeah. So
Okay.
basically, yeah. And also, if we find some other mutations, in that report, then my armamentarium is widen, and I may think differently also. But treatment free is a very important part, definitely.
Fair enough. Yes, madam, please. BK Smritima.
Yeah, if there's no other comment from others, I'd just like to say that actually the data on third line cetuximab has come before we use liquid biopsies.
Yes,
So
ma'am. I've
we
just
have,
shown that slide.
yeah,
Yes.
so we have had experience
Yeah.
with using it as third line, but I'm quite sure that the patients who actually responded were those who had, the mutation had disappeared. So, but we didn't have the data then, so we used it irrespective without the liquid biopsy. But I think today's day, I think we should use that liquid biopsy if possible. Though one may say that sometimes the tumor may not shed, or, but it's the other way around. So I think we would use. What do you do in your practice?
Yeah, I've started going to that, ma'am. I think a majority of these patients have significant disease burden. It's unlikely they are not going to shed. So the liquid biopsy, I think, would help, with my decision, because in our scenario, it's still an expensive option relatively. So I do use liquid biopsies more and more, ma'am. And as Madam said, these trials are from 2007 and 2008. So even before liquid biopsy was a concept, third line options with Citax and Pantrimab existed. And this again, it's very nicely named as the Santini's hypothesis, but if you look back, it's essentially logical. You have more clones in the beginning, you have resistant clones in between, you switch off the treatment, and then you have some more sensitive clones. That basically is what this hypothesis is. And this was one of the earliest studies, which was nicely named the cricket study. And I think here is the role of liquid biopsies, where clearly if you are RAS wild type ctDNA on rechallenge, you do better as opposed to RAS mutant. So I think treatment-free interval, as Jyoti ma'am said, is important, but liquid biopsies are very, very important as well. And these are more studies that are on their way. There's the Fire 4, there's the Capri 2 going. All of these are going to answer this in bigger ways. And there are close to 10 studies which have looked at anti-GFR rechallenge. The thing to note is that the overall survival advantages that they give are around 6 to 10 months. But we must understand that this is third line setting where, beyond 6 months is essentially good. All right. And there's a systematic review of the same which says that, if you are RAS wild type, essentially by ctDNA, then your patients are going to benefit. So this is what I do in third line. I essentially start my patients off on task 102 and wait for the liquid biopsy. And then I either add BEV or an anti-EGFR based on the report, because oftentimes a lot of patients are not willing to wait and they want some therapy. So this is the basis I use for using BEV or an anti-EGFR. The last two bits, NeoRAS. Are you convinced on NeoRAS as a phenomena or not? I'll start with Dr. Amol, and then all of you can give your opinions. Do you think the NeoRAS wild type is an actual phenomena, and how clinically relevant is it? Dr. Amol? Okay. I think he's not there. Dr. Minish, your thoughts on the NeoRAS, phenomenon? Am I audible? Okay. Dr. Minish, any thoughts on the NeoRAS wild type? Anyone? Dr. Jyoti, Dr. Amol, Dr. Taha? So what the NeoRAS wild type essentially says is that if you're, RAS mutant at the baseline and you give standard chemo plus Bev, the RAS actually becomes wild type. And it's happening in close to 5 to 10%. And there are some studies which say that this happens in 70% of patients. So any thoughts on that? Anyone?
See, this is a known phenomena when we are looking at many malignancy. What we initially believed that it is a clonal disease and continues to remain clonal. But we have seen this repeated time and again with breast cancers and other malignancies that there is a switchover. You keep hitting one target, that target is lost, and then you get another one. So this is not a new thing. KRAS, if it was not detected earlier or NRAS not detected earlier, doesn't mean it was not there. If you're detecting it on your subsequent thing, and you can still target, provided that the test is reasonable and you can give the treatment. So we have
Yeah.
seen this routinely, and
Yeah,
we have done
so
it for breast routinely. We have not done it so often with colon, but when you keep doing 2 times, 3 times, you would realize that they are also continuously changing. And this is not with only chemo; it's only mainly because of targeted therapies.
yes. So
Yeah,
the
I
the
think I
point,
think I agree
yeah,
too
ma'am.
that essentially these the receptor migration or mutation change, they happen, and they happen with the pressure of therapy what we are giving, and there can be evolution of clones in different manner, and we need to act upon reasonably on that information.
Sure. So the point I was trying to highlight here is that, uh, essentially, if you are KRAS mutant in the beginning, and there is a selection pressure on these clones, 10%, 15% is okay, expected. But there are some studies which are saying that around 70 to 80% become RAS wild type, and that is really surprising to me. And this is not one or two studies, a few studies have shown this. So I think there are some reasons as to why this happens. Bev might have greater activity on RAS mutant clones. There is tissue heterogeneity, and this we all know. And whether it is the method of assessment that plays a role. And I think we'll see more of this, and it gives us an option for using anti-EGFR in the coming future. I think that's the point I wanted to convey. The survivals, again, when you use this approach, go up to 1.5 to 2 years, which is pretty good. Anyone with experience on KRAS inhibitors? My first question is, how many of you have seen a G12C in a colon? Has anyone seen it? First question. Anyone?
No.
Dr.
G1 to
Tahad?
D, not
Sir?
C.
No,
G1
no,
to D.
no. I specifically asked
Yeah, that's what
G12C.
I'm saying, Anant. Yeah, I didn't see G1 to C. D is okay. Yeah.
No, I've not seen.
Yeah. BK Smriti, ma'am, sorry, I missed this one. Please.
First thing was about the NeoRAS.
Yeah.
The metastatic CRC is a continuum of care sort of thing. And I think this is some very important data which we cannot ignore. So I would offer it to a patient who became negative down the line if I find that I don't have other things to give. And especially this data of almost a year of progression, free from progression.
Yeah.
I think I would definitely offer it
Yeah.
to my patients. Now, I have one patient with a KRAS G12C, but the access to sotorasib and edgarasib is, they're too expensive. So
Yeah.
this patient is in third line. So, I mean, he's an ideal candidate, but the cost is going to be prohibitive.
Yeah. And just to add on to what you said, ma'am, I think a lot of this antigen change, we need to be sure of the test we are using. I mean, we really need to be sure of how well validated that test is before taking these therapeutic decisions. So I have two patients with G12C. I started one, he was willing to do anything, didn't do very well. I started him on sotorasib and panitumumab. He progressed in a month or so. So, I think we need more experience with this combination. And it's very rare in colon, or for that matter, I think every cancer. I hardly see a G12C.
So I have
Um,
also
Just one
experienced
comment.
one patient. Sorry, I've also
yeah,
seen
ma'am, please.
patient
Yeah.
with this mutation, and but again, the affordability is the question at present. So
Um,
are we getting some compassionate access or anything?
No, no, ma'am.
no.
No. That patient had to move heaven and earth, spend a lot to buy that drug. So they're not,
Okay.
yeah.
The cost is 18 lakh per month.
Yeah.
Yes, sir. That's what I said. He moved heaven and earth. Yes, ma'am. Because
Just
ma'am.
one comment, that if you look at the data, if you look at Crystal or the other code break, the difference between standard of care, I mean, if you look at the difference in third line, is maybe 2 to 3 months only. I think it needs to be moved up in the setting, and that is being investigated, where it would not be used, it has to be used in combination with other therapy, not alone. So maybe
Yeah,
cetuximab and this plus chemo, that would be it.
yeah.
So, but in third line, even though it is showing significance, the difference in median PFS is maybe 2 to 3 months.
Yeah. So some of the investigators at MD Anderson who run these programs, they're actually looking at far stronger drugs. And it's a question of 3 to 4 years, they say, that you'll just have pan-RAS inhibitors, which will be better. So one, I take your point that I think if you use them earlier, they're probably going to do better. But per se, they don't seem to be very strong drugs. I mean, okay, they're there, but they're not very strong options, is what I feel. But I think these drugs will get better in 3 to 4 years' time. Oh, yeah. So as Madam had said, the code break and the crystal both looked at PFS and OS, and results have been presented. So with that, I'd like to thank my panelists and BK Smriti ma'am for an interactive discussion. I'd like to thank Merck as well, and thank you everyone for your attention.
So, I would like to thank all the speakers and the moderator and the panelists for that very interactive session, and also Merck for having given us this opportunity to discuss all these things threadbare. And I think, actually sharing one's experience is really the way to go forward. And so we have had a whole lot of things beginning from biomarkers, how to use RAS wild type and mutated versus left versus right, and the biomarkers, how to bucket these metastatic mCRC. So all the data has been covered. So I don't think I can, again cover all the points, but important to remember that the side and the biomarkers are very important, and that treatment of metastatic CRC is a continuum of care. So whatever new options that do come up, like it was mentioned, re-challenging with EGFR, and on the other side, the neo-RAS. So I think all these options always need to be explored in your patients and given a chance. So I think with this, I would like to again thank everybody, and I hand it over to the organizers.
Thank you. Thank you, Dr. B.K. Smriti, ma'am. It's been quite an insightful discussions and to understand the school of thoughts of all our esteemed guests on this panel. Thank you, Dr. Anand Ramaswamy, to moderating the session and making it quite interactive. Uh, Special thanks to Dr. Advait Gore for walking us through the different biomarker setups in different therapeutic trials and regimens available. And lastly, the panelists for giving their opinions on different clinical scenarios they've had in their clinics. It has been quite an insightful discussion, and we have a lot to take away from this session tonight.
Neha,
Thank you. Yes,
hi.
Neera.
Neha, just to interrupt, like we have 115 audience, 115. people listening to us.
That's great. I hope this trickles down to all our audience who will be listening to us, and we have great takeaway for the precision oncology in mCRC. Thank you, everyone, once again. Good night.
Thank
Thank
you
you,
very
everyone.
much.
Thank you. Thank you.
Yeah.